Good morning all. Today my paper presentation is on the topic, the assessment of patient adherence to exercise program prescribed by physiatrists by self-demonstration in a tertiary care center. The degree to which the patients adhere to the home-based treatment program, it is responsible in some part for the success of exercise program. And it is recognized that the patient's perception about their injuries, resultant symptoms, and the coping mechanisms, these are influential in determining the level of rehabilitation adherence. And also other patient factors like educational status, socioeconomic status is also found to be influencing the rehabilitation adherence. So the relevance of my study is that this paper will discuss the patient adherence to exercise program with reference to its occurrence, measurement, and the determining factors, and will conclude by providing the recommendation about how the physiatrist could identify the patients who might be having these problems with adhering to exercise program. And also this study will emphasize on the need of reinforcement of the exercise program on a regular basis on further follow-ups, thereby increasing the rehabilitation adherence, and this will lead to the success of the exercise programs. And my objectives are, primary objective is to assess the patient adherence to exercise program prescribed by physiatrists by self-demonstration. Secondary objective is to compare the patient factors like age, gender, educational qualification, occupation, socioeconomic status, diagnosis, and the type of exercise between the groups of self-demonstration at 2 and 4 weeks. And this study is a prospective observational study done at the Department of PMR, Government Medical College, Trivandrum, for a period of 1 month. And the study population included those patients who visited PMR OPD with osteoarthritis knee, lower backache, or rotator cuff injury. And the sample size was 30 patients done by consecutive sampling. And the inclusion criteria include those aged above 18 years, patients with clinically and radiologically proven osteoarthritis knee, rotator cuff injury, or lower backache, patients with intact comprehension and can follow simple verbal instruction, patients who are able to do the self-demonstration of the exercise program. Exclusion criteria included those patients with non-cognitive impairment or patients who are bedridden. And the data collection tool was a semi-structured questionnaire. Study procedure was that all those patients with the above said diagnosis, they underwent initial clinical assessment, following which they were prescribed the specific exercise program. And on the follow-up at 2 weeks, they were asked to do the self-demonstration. And for those who failed to do, we have given the reinforcement. And the reassessment was done at 4 weeks. And the comparison of patient factors between the groups of self-demonstration at 2 and 4 weeks was also done. Coming to the results, out of the total 30 patients, 67% were female. And on distribution of education, an upper hand was those for high school education. And coming to occupation, 46.7% were homemakers. And the distribution of socioeconomic status, 73% belong to BPL category. And coming to diagnosis, it was almost equally distributed with a slightly upper hand for osteoarthritis knee. And the exercise prescribed for OA was isometric quadriceps exercise. For rotator cuff injury, we have prescribed Codman pendular exercise. And for lower backache, we prescribed pelvic tilt exercise. Coming to the comparison between the self-demonstration group at 2 weeks and 4 weeks, out of the total 30 patients, 16 were not able to do the proper self-demonstration at 2 weeks, and 14 were able to do. And we have reinforced those 16 patients, and at 4 weeks, only 3 were not able to do. Rest 13 were able to do the self-demonstration properly, and McNemer test was done, and it was found to be statistically significant. Comparing the patient factors like age distribution, from this graph we can see that slightly lower age group was able to do the proper demonstration at both 2 and 4 weeks, but it was not statistically significant. And coming to the gender, this also, the females were of upper hand, but it was doing both, demonstration was properly done, but this was not statistically significant. And coming to education, those with high school and above, they were able to do the proper demonstration at 2 weeks, and it was statistically significant at both 2 and 4 weeks, that higher education people were able to do the exercise. Coming to occupation, at 2 weeks we can see that those belong to homemaker category, they were not able to follow, rest elite group were able to do, and it was only significant at 2 weeks but not significant at 4 weeks. Coming to socioeconomic status, those belong to BPL category were not able to follow, and it was significant at 2 weeks only, not at 4 weeks. Coming to diagnosis, exercise, those were not statistically significant. So concluding, the self-demonstration by patient can be an effective tool to assess the patient adherence to exercise program prescribed by physiatrists, and it can be correlated with various patient factors as seen in our study. And there is significant improvement in patient adherence on reassessment at 4 weeks after reinforcing those patients who failed to do at 2 weeks. And there were significant differences in education level between the self-demonstration group at both 2 and 4 weeks. And there is significant difference observed in occupation and socioeconomic status at 2 weeks only. Hence, reinforcement plays a very important role in adherence to the exercise program prescribed by physiatrists. And the self-demonstration by patients might not be always possible in a busy OPD, but the physiatrist should find out some measures to reinforce such patients to improve their adherence on a regular basis and on a regular follow-up. And adherence depends upon the patient factors like education, occupation, socioeconomic status as seen in the study. So we should keep these factors in our mind while prescribing the exercise programs. And also this undictation of this adherence, lack of adherence, it will lead to altering the exercise program. So it should be kept in mind. And also it is suggested to be responsible for non-significant research in clinical based research. And the limitations of my study, it was a small sample size and a short period of time was only available. These are my references, and thank you.
Now the topic is open for discussion and questions.
Actually, that topic is a very, very relevant one, and quite often we see that the patients do not follow the instructions when they come for follow-up, and especially when we are dealing with the self-program, self-exercise and all. And one advice which I can give you or to the patients is that you teach the bystander also, the spouse, husband or wife also, the same exercise program so that they can reinforce the program at home. And quite often when we see the patient the second time, they do the exercise improperly or they do not do the exercise.
Yes.
So if you insist on the suggest the husband or wife also to reinforce the exercise, that will be helping.
Okay, sir.
Have you demonstrated reverse demonstration? Apart from demonstration, have you practiced reverse demonstration?
No, sir, only demonstration was.
From the patient part?
At the first time, I have done the reverse demonstration also. Then on further follow-up also, we would ask them to do. At the first time, I have done the demonstration and reverse demonstration was also.
So how can you improve the adherence? What all methods have you find out that you can improve the adherence level?
So one thing I think is that the follow-up period can be shortened within 1 week or 2 weeks till that symptoms subsiding of the symptoms. We can increase the follow-up period at a lesser period. And other thing, as sir said, we can demonstrate it to the spouse or the caretakers. And this reverse demonstration should be done all the follow-up periods. And we should find out the time. In the busy OPD, I don't think we can do it for every patient, but I have to find out the time and ask them to do. And also nowadays, technology has advanced. YouTube videos, and we can suggest them for proper demonstration.
Modern gadgets.
Dr. Drini, good presentation. Nice area of thought. Okay, but just by demonstration, how can you make sure that they're doing it every day? You should have. I mean, is it not better to have an exercise diary or something? Which, again, it's not foolproof, but
Yes,
but good way to.
Yeah, that would be a better way, sir. In future,
This is just a comment. You have identified educational level, socioeconomic status, and occupation as the 3 real causes for non-adherence. How can these be remedied? It's a rhetorical question.
we cannot go back and teach them, we can improve their education, but like this reinforcement is our main area. We can reinforce them. So we should keep these factors in mind, that because of these education or socioeconomic problem, they may not be adherent. So as physiatrists, we should be keep these factors in mind and prescribe, and we can reinforce them at all follow, rather than those who are having higher education or having elite occupation. We should focus these groups, and we should be doing more reinforcement. More focus should be to that patient.
Thank you, Drini. Thank you very much.